Okay, we're going to get started now. So thanks, Dr. Deakin, so much for giving up your Sunday morning to talk to us. So people who don't know, Dr. Deakin is a GP and she's written a book on functional symptoms. Do you want to hold it up, Gillian?
Yeah,
Yeah,
that's
this
my
book,
book.
What the Hell is Wrong with Me? And I think a lot of us have had those thoughts and said that same thing when we've come down with these symptoms or when we've received a diagnosis. I certainly remember when I saw functional weakness, I'm like, what the hell is this? This sounds like you're minimizing whatever I've got. It's more than just weakness. So a lot of us struggle to find a GP who does have experience in FND or who even knows what the condition is. And I guess we've had a lot of name changes, which can complicate it. But what motivated you to write this book?
I think that very issue, people would come to me with symptoms and I received zero training in the treatment of functional conditions, zero. And so I'd have people with these symptoms and, I would naturally try and do all my due diligence and do all the checks to rule out physical illnesses. If there isn't a better term, Kate, do you have a better term for a non-functional condition? Is there a preferred term you like to use in your... I'm
No,
just calling it physical
yeah,
rather
yeah,
than functional. I'm just sort of using that as the attempt to
yeah,
differentiate. And so being a curious person and a researcher, I've got a research degree before I went into general practice. So that prompted me to go back into research and see what I could find about what explains these symptoms that currently don't have even a good term that's chosen. So, FND has really led the way. I think, your organisation's led the way to accept that term functional. And I've happily accepted that. But if I talk to a lot of people, they struggle with that term still. It's like, what does that mean? Explain it? And I go, yeah, I know. It's always hard to explain. The other reason I wrote the book is that once I did know myself and accept the idea and the pathophysiology, so that means the cause of functional conditions. When I myself could recognize someone in front of me who had a functional condition, I found it very, very hard to persuade the patient that that indeed was what it was, because I didn't have the language, I didn't have the means, I didn't have a good way to describe it. So I thought that this is not satisfactory for either the doctor or the patient, of course, more importantly. So I set about to research it, and the book is the result of that.
Yeah, yeah. And the term, I mean, there has been a lot of name changes, and I kind of think because there's been these name changes, that's why maybe some health professionals are not up to speed with the new name, the new research. And to me, functional, when it's explained as there's a disorder in the functioning of the nervous system or the functioning of the brain or the way the brain communicates with the body, that does make sense. I also did the same thing when I came down with a condition, going into the research databases, because I was a researcher before I went into OT, before I went into this organisation, and looking at the research. I don't know if you noticed, there was this real divide in the research. Like I was seeing the neurology things, which was looking at what was happening in the brains of people with FND. And then there was a lot of psychiatry and a lot of historical stuff around conversion, malingering behavioral things, secondary gain. And I can remember as a person with lived experience and a researcher thinking, this is not gelling with me. And that's what sort of got me into research knowledge translation was, the literature was confusing and not everyone has access to the literature. And this book, for people who haven't read it, it is written in a way that the general public can understand it. It's not your scientific literature from the university databases with all these sort of complex terms. It is written in a way that people can understand it, make sense of it, and utilize it in their life. For all the people attending, you're welcome to jump in and ask questions or put questions in the chat. So Charmaine has said, great book, thank you. So it is something that a lot of our members have read and have benefited from them. And one of the things when I was looking at the book, I was quite surprised. you mentioned that in general practice, 1 in 3 of your patients were presenting with functional symptoms. I'm like, well, if it is so common that 1/3 of the patients going to a GP have a level of functional symptoms, why is it not known about?
Yeah, it's an excellent question. And it is, in a way, if you think about it, in those 1 in 3, we're including irritable bowel. So doctors have described now and accepted, and there are what we call Rome criteria, patients who have this list of symptoms and have this test done and they're normal and so on, get the diagnosis of irritable bowel. Now, probably a lot of the people listening right now have some irritable bowel symptoms. A lot of them do. Will have some bloating, some abdominal discomfort. It's very common for there being an overlap between the gut symptoms and the neurological symptoms if you have a functional disorder. So GPs can diagnose and do diagnose irritable bowel syndrome. They diagnose fibromyalgia now. Again, that's another condition that we GPs have to go through a list of exclusions to make sure we're clear we're dealing with fibromyalgia, and that's another functional condition. These are quite common disorders. Migraine is sort of not fully accepted as a functional condition, but there's an element that's functional because you're perfectly well one day, then you have this blinding, terrible headache, and then the next day you're perfectly well, and all the tests are normal. So in that sense, it meets the criteria for functional disorder. But I'm not here, I'm a GP, I'm not here to define exact definitions and so on. I'm here to try and work with people who are patients right now living with these conditions and go, what are we meant to do? How do we take the next step forward? So the first thing is really important that you work with a GP who accepts that your symptoms are real. And that's like really fundamental, that you're not imagining them or faking them. And so that's absolutely step number 1. Step number 2, you feel confident the GP has done their due diligence in doing tests, and they will listen to you if you say, look, my symptoms have changed, and you need to be able to feel safe that you can report any change in your symptoms, because all of you are capable of forming other conditions like anyone else, so you always should be listened to. And so this is why I'm saying the relationship is actually really important. The third thing is I would encourage them to read my book, get your GP to be familiar with, even if my book is not the definitive book about how we should talk about functional conditions. Sorry, there's someone on not on mute, I think.
Yeah, I just muted. Hold on, everyone, please have your microphone on mute unless you're talking.
Yeah, okay. Welcome, whoever that was, welcome. And so I've lost my train of thought, but just I'm saying to try and at least agree to some terms so you can feel that you're discussing your symptoms within a certain framework. And that's why I use Dr. Kasia Kozlowska, and I need to acknowledge her straight away that my book's based on not my clinical experience, yes, but I've based it on the research by the experts. I haven't done that research.
Yeah.
And Kozlowska is a brilliant, she's actually a psychiatrist, but she has a very fine understanding of how functional symptoms arise. And she defined those 7 body stress systems, and I found that a very helpful way for me to talk about the conditions. Kate, do you agree with that?
Yeah, well, absolutely. In terms of what's going wrong in the body, and you're mentioning about how the GP explains it to the person, I think that's really fundamental. And I remember something was raised with me, and my mum was like, well, she's not making this up, that's ridiculous. And it was framed in a way, your child's making this up, which clearly I wasn't. So it's the way it is explained to the person, which is really, really important, and trying to explain the physiology of it, which is what I think you're trying to do in terms of like, someone said, your brain is glitching. It's whatever works for you. That brain software explanations often used, but what's going to work for that person, and also what that person understands. And they're, are you talking to a 6-year-old child, or are you talking to a medical practitioner who works with people? So using that language that's going to work for them and also make sense for that person. And a lot of people do seek explanations, and they're like, this is really severe. What is going on?
Yes. And so that's right, because some of these symptoms, and I'm sure you're aware, are quite disabling at times. And often the research shows that people living with functional conditions are often more disabled and have more suffering than people with physical conditions. So certainly functional epilepsy is much more disabling than many forms of physical epilepsy, functional seizures, forms of people with epilepsy. And so, I think it's important that, we slowly get the attention that you all deserve and the recognition. So I'd like to think my book's just that first step towards that. And it is being read. I'm now distributing freely to any GP, so they're welcome to contact me.
That's awesome.
And I'm just setting it out as a PDF to any GP. So I hope that
you can get a copy of that book free.
Guys, please keep your microphones on mute, because it does get hard to follow the conversation. Is that David? Can you go? Put David on mute. Sorry, guys.
So would you like me to go through the 7?
Going through those 7 stress systems on the body in terms of how you might explain FND to someone that's come to see you.
Yeah. So what must be very frustrating for people with functional disorders is that they might present initially with one symptom, but then what's so hard is it doesn't sit tidily and behave in a predictable fashion. And that makes it easier for me as an experienced doctor to diagnose it. Like I had someone in yesterday who was getting leg twitches, and she was terribly worried to be nutritional and this or that and that. And from her story, and I was able to clarify it very easily from her story, I was able to confidently say it was a functional condition. And so the conversation veered from being, I need blood tests and so on, to how are we going to manage your functional condition? And that takes, it's quite a big swivel for people if they're not used to the term and the concept. But it was rewarding because she was able to understand why I said it was functional. And there's a lot of ways I could prove it to her. And then what to do. But the other thing about having a functional condition, not only does it vary quite a little bit, but then you suddenly get other symptoms like the upset gut, or you get brain fog or fatigue, overwhelming fatigue, and problems like that. And these can all make you seem like you could end up being called a hypochondriac, which I think is a dreadful term. But it just means you've got, I would say it would be kind of an embarrassment of collection of symptoms, and really hard. Do I now need to see a gut doctor? Do I need to see, someone for my eyes because my vision's getting disturbed? But I'm trying to, in my book, say there's one background cause for it all. Well, not one. There's usually multiple background causes, and if we turn away from the symptoms and try and focus on the background causality, we may be able to lower the incidence of the symptoms. That's my hope. Katie, do you think that's a good approach yourself from someone with experience in?
Often, and we tend to find there is background stuff going on, and if you just focus on, hundreds of different symptoms that people are dealing with, it's like, how can we, and you talk about it in your book, and Kasia talks about it, lowering your body arousal. So trying to lower that threat response in the body. And there often are background causes. Like, I never find anyone that just has FND. People always have a combination of issues going on.
So I said I'd go through them, and let's go through them. And so the way Dr. Kozlowska formulated this research, and we all learned this in second year medical school. So every doctor who's studied medicine is all aware of these systems. So it's no revelation to doctors. It's just never been translated into the clinical setting, and that's the problem. So the first system that many you may be aware of is the autonomic nervous system. So the one that from the calm rest and digest, when the whole body is working in its natural relaxed state. Then there's the fight or flight system, and I suspect many of you are familiar with that. Fight, flight, and freeze. Sometimes it's useful to add on the freeze. So it's why people sometimes get paralysis or cramps and so on. And so that's the first system. There's many, many other symptoms that relate to the autonomic system. And I'll just go through some of them, change in heart rate or blood pressure. So some people will get POTS, for example, change in the respiratory rate. So they can be hyperventilating, and hyperventilation itself causes a whole cascade of symptoms, which can get tingling around the mouths and stiffening of the body and fullness in the head. And in itself, it can become very alarming. So it's very important for everyone to recognize if they're over breathing. That's what hyperventilation means, just simply too much breathing for the task. And many of those symptoms will arise. Sweating, change in skin color, the gut disturbance starts with the autonomic nervous system, and just body tingling. Tingling is a symptom, and many of your members, Kate, would have had tingling and always worry whether they could have MS, and of course, which is a symptom of MS. And that's obviously, we're very grateful that we can do MRIs now and help to rule out MS. But there's many people who have little minor changes on their MRI and they get over-diagnosed with MS. And we have a responsibility to undiagnose those people and help them to recognize that it is functional. That's very hard. It's very hard to do. So that's outside my pay grade. The next system is just the hormone system. And I suspect many of you have known that you can have a disruption to your menstrual cycle. There can be fatigue because cortisol levels changes, weight changes, energy problems, sleep problems, loss of libido, prolonged illness, just feeling unwell for a long, long time, disturbed brain function, sexual function, skin temperature changes, and so on. So the change in the hormone levels are very common in people who are chronically unwell, whether it's physical or functional. So that's another thing that should be looked at as part of the functional illness, rather than pursuing, I need to have my cortisol levels measured, which I find is quite a common problem. People often seeking to have their cortisol level measured. Not useful, generally. Disturbance in the immune inflammatory system. And this is an interesting area where people will break out in swelling and rashes and pain, and upset gut, and even prostate. That can happen. People can get an inflamed prostate and worry about why their prostate, they can't pee normally in the men. Itch around the anus, an anal itch, pruritus ani it's called, is also a related to activation of the body stress systems, so through the immune system. So there is real itch, real inflammation, and it fluctuates with what's going on in people's lives. The next one is circadian rhythm. I personally have had this when I'm generally blessed with good health, but when I did night shifts in intensive care, I got really disrupted circadian rhythm, and I got my gut really didn't like it. I had pain and hunger and gnawing feelings and really unpleasant. So never had them since, but I got that when I was doing night shifts. So I'm well aware of these things. Your circadian rhythm is so important for just falling asleep and having a healthy sleep cycle, waking at the right time. Fatigue, of course, mood changes, poor concentration, very common with the poor circadian rhythm. Is that common? Do you find that common, Kate? That
it's really common, and we've got a lot of people that have such poor quality sleep and such little sleep, and you're thinking, how can they're trying to do all the right things around sleep hygiene. They've tried melatonin and everything that you think you'd recommend. They've tried and they're doing, and they're still not able to get that good quality sleep and fall asleep and get sufficient sleep. And I think that's one of the issues. And you sort of feel like people just can't get better if they're not getting that deep restorative sleep.
Yeah, I agree. I think it's so critical. And I know, as a mother of two young children, I when I was, that need for sleep is just so important for your mental health and your well-being, your physical well-being. So I'd spend quite a lot of time trying to optimize that. And you're right, Kate, we don't always succeed, but it should be something I think should be prioritized and trying to give the maximal chance for it. Many people know when they're able to exercise well, they sleep better, but a lot of people find it just so hard to start that exercise program because they're so fatigued. So that's why as a GP, I'm very keen to get in very early and start making the changes. And that's why I can be successful, because I'm diagnosing it very early before it's bad.
Yeah, real severe disability happens.
That's right, Kate.
So many people, they just, they have all these symptoms initially which are not dealt with, and then it just escalates and escalates and escalates.
That's right. Yeah.
End up sort of like this downhill spiral, and when you get to the bottom of that, it's very hard or impossible to come back.
Hard to get out. Yeah. So the next system is the skeletal-motor system, and Dr. Gillian describes that very well. So that would affect many people with FND, of course. So muscle tension, pain, cramps, tremors, weakness, simply a postural change. Just a change from being upright to being that's a stress response. Of course, you can see that if a gun goes off or something, people will have a reflex protective thing. But if they're under the threat of something like that, then their posture could be, held in that poor position. Paralysis, difficulty with speech and swallowing, and many of those are obviously have physical causes that could explain every single one of them, and that has to be checked. And then, we try and treat them as a functional symptom. And the speech pathologist can be wonderful to help with that gut there, Kate. Have you seen that yourself? No.
Yeah, I mean, the speech and swallowing certainly something that's come up. And when people have had swallowing issues and not been able to eat or drink, I've seen a massive decline because they're not getting the nutrition. And then their body's in greater stress because it's starving or dehydrated. And then we've had issues with, some people not being medically intervened and getting really, really compromised because going back, that swallowing hasn't been addressed.
That's right. That's it. The sixth condition is the disrupted microbiota, the gut-brain system. So many people now, it's been recent information, hasn't it, over the last 10 years, I guess, people are recognising that gut health is so important. What you eat, what bacteria live in the gut, how the gut functions, and then how that affects the brain, and they all talk to each other, of course. So let me say right now, the people researching the microbiome, A, they know it's important, but B, they don't know how to really fix it. I think it's really important. People are spending a lot of money buying packs of gut bacteria in the hope. My approach has always been not really to do that, but to focus on the diet recommended by people who do this, which of course, luckily, is often the same sort of diet, which has got that high fiber, so the bacteria thinks to eat in the lower gut, that high residue, so that, lentils and chickpeas and nuts and seeds and peas and beans and whole grains, and so on, and a low sugar, low alcohol, which helps the gut. And I think many of you probably know to focus on diet. Is that something talked about much in your organisation, Kate?
I think we do see issues with gut, like that comes up really commonly. The irritable bowel, and then also bowel incontinence, urine incontinence. Also, we see, a high level of people with eating disorders where they're not getting the nutrition that they need. So then we've got the comorbidities happening.
That's right.
And so I find that one can be problematic, but it is definitely, and a lot of people have changed the diet, and I think different diets work for different people, so people addressing what works for their gut health, which is going to be different for other people, like that sort of standardized dietary program may not work for everyone, but
you're absolutely right.
It's working out what works for that person, like you mentioned, the lentils and the nuts. That might be great for some people, but if you've got other conditions,
that's right.
Rachel has a question. Rachel, did you want to jump in? Thanks, Daddy. I
just want to make a little comment that I think, these are really great suggestions. And I think with FND, everyone is so individual and everyone tends to have intersectional issues. And with FND, like I'm hearing like lentils and all this, like if I have lentils, I could die. I've got gastroparesis and I breathe it into my lungs. So I mean, it's great to have these good ideas, and yes, this is what we do, this is what we do, but a lot of us can't do these things. And like with sleep and stuff, I've never been able to sleep all my life. I also have bipolar 2. Like, a lot of us have intersectional things happening, and when we have intersectional things, and even with the FND, like my gastroparesis has caused my FND's caused my gastroparesis. I get things mixed up a lot. FND complicates things, intersectional things complicate things, and when things get complex, it's much more complex than just a simple, this is FND, this is what we do. It's every single person with FND does need a unique approach. Sorry.
Rachel, I agree. Right. Yeah.
That's all I want to say. And I love that you've got like things to do, but it does need to be an individual approach for each person.
Yeah, and everyone comes down with FND for different reasons. So it absolutely is the individual approach for everyone. And like even with the gut, looking at what does work. So a lot of people do have gastroparesis. So what they can have is very different to someone else. So it's, and also getting in early before and people end up with all these complications, because you know, so often we're seeing people at the bottom of the spiral by the time they get to us, and they eventually get a diagnosis. But often there's been things higher up where we could have intervened.
Yeah, that's right. I totally agree, Kate. So Rachel, thank you so much. I think you're absolutely right about your point. And so I probably would like to get to talk about how to fine tune and do that. I guess at this stage, I'm trying to talk very broadly, but you'd be right. If you're my patient and you say, what happens when you eat lentils? And you go, well, you know, not for me. Of course we, you know, listen, right? We hope we would. So yes, big picture, you know, lentils and legumes healthy, except for some people. For example, people with irritable bowel certainly can't eat them very often. You know, that's just a fact. You know, it gives them too much. They can't digest them, and they're hard to digest. So, you know, good point. I'll just finish off on the final system, which is the brain stress system, which of course is, you know, relevant. And we sort of put that separately. You can see I've kind of mentioned the brain a number of times, a number of these systems. Of course, they all interact, but the brain itself can misbehave and malfunction during a functional disorder of any type. And you can have that poor memory, poor concept, can't remember the name of your neighbour or something, kind of have a very poor functioning of your brain, forget words, forget things, forget events. But it also, you know, leads to exhaustion and irritability, mood changes, and so on. So in itself can lead to quite a lot of symptoms. So that's the 7 symptoms, and I try and describe them like that because doctors like to think in systems, and so it may help you to go in and say, look, I want to focus on my gut today, and then I'm going to get back to focus on these later. Because if you go in and go, you know, I've got all these symptoms and it's chaos. Doctors, as you know, GPs, we're all under the gun. We're all trying to do a lot in a very, very short period of time. So I'd probably recommend that you choose something that you think is realistic to work with in the time that you have available. And even if it's not done, come back again and pursue that. Don't quit. You're dealing with very complex and difficult things. I suspect many of your members, Kate, would need not just a GP, you'd need a multidisciplinary team. Is that what?
Oh, absolutely.
Yeah. And so GPs have a probably less important perhaps in people who are members of your fine organisation, but my book's written for people, I hope, at that very early stage, like, oh, I've developed this new symptom, what's going on? And that's when I would like to be able to intervene and stop, you know, the whole spiral as Kate describes, you know, because we do know people do a lot better, and that's my experience. People do a lot better if I'm able to nip it in the bud and go, let's treat this as functional now. And, you know, am I going to miss something? Well, I see their symptoms disappear, right? That's my job. I have to watch and see their symptoms abate or at least become much more manageable than when they first come in. If I don't see that, I'm definitely going to pursue things further, aren't I?
Yeah. And I think, like, even for me, like, they were definitely sort of I didn't pick it up at the time, but prior to me developing the full-blown look like a stroke, prior to that, there was all these little episodes where I'd collapse and end up in hospital, and they didn't really know what was wrong. It's like, you're fainting, you're not eating enough, you're doing too much, all this sort of stuff. And I'm like, they were warning signs, you know, but we didn't know what they were. You know,
Right.
by the time I'd ended up in hospital, they didn't know why I'd collapsed.
Yeah.
So, you know, I think had it been picked up there, and then you can intervene and go, okay, well, maybe you are doing too much, whatever. It could have been stopped early on. But for a lot of us, you know, it will take so long to get a diagnosis to really understand what's going on, by which stage we're often too far down the downhill spiral.
Yeah.
Now, Catherine's asked, you know, you've spoken a lot about fatigue, you've spoken about inflammation. So Catherine's asked, you know, what's the difference between FND, you know, your ME, chronic fatigue syndrome, and fibromyalgia? Because they're all sort of, a lot of people have them coexisting.
Yes.
Along
So
as
it's
well.
a good question, and it is it's not that complex if you think of, if we try and just see them as overlapping Venn diagrams, you know, just overlapping conditions. Some people have pure fatigue and they don't have any pain. Some people have pure aches and pains, but they're full of energy and don't have fatigue. But many people have some fatigue and some aches and pains. And so I know fibromyalgia is often described as people who have like exhaustion and flu-like symptoms. So that has a lot of the fatigue in them. These categories and these diagnoses are only useful if you find them useful. And so if it helps for you to say, yes, my pain is my biggest concern right now, you'll be focusing more on the fibromyalgia management and treatment. But if your fatigue is the overwhelming and disabling symptom, then we clearly would be shifting towards looking at how to treat fatigue, which you probably, many of you know, is one of the harder symptoms to treat. Yeah. So
And
I
would
don't.
complex regional pain syndrome come in under that as well?
No, that's currently it is seen as functional, we think, but it is a distinct symptom. So fibromyalgia, any of you who have it know, it's fairly symmetrical.
Yeah.
You're aching sort of in very specific areas around your knees, around your joints. There's very typical points where you're at it, whereas complex regional pain tends to be in one hand. Usually when it starts often in one area, commonly in limbs, sometimes elsewhere. Pelvic pain is sometimes a very complex type of pain. And so, but let's talk about complex regional pain, typically in a limb, often after an injury. And then the pain should get better. You know, everyone gets better from a sprained wrist or something. Complex regional pain, the pain just gets worse and worse, and that's when it should be diagnosed, ideally again very early before there's disability sets in. So I hope that helps a little bit to see how they're separate. Yeah.
Does anyone want to jump in with a question? So feel free to put it in the chat, or you can raise your hand. So to raise your hand, I think do you go to more? I think you might go to more and then react if you want to raise your hand, or you can, someone has asked about triple PD. So that's your, the dizziness one.
Mm-hmm. What's the question?
So someone, Erin, what did you want to know about triple PD, about how to manage it, treat it?
Well, I was initially diagnosed with triple PD, and then I was diagnosed with FND afterwards. So I'm just wondering, like, so I know triple PD is I think it's a class of FND. I'm not too sure.
Yeah.
I just want to know, like, how does that work in with FND? Like, do I refer to it more as triple PD, or should I refer to it as FND, or is it just one and the same? And yeah.
Do you want to tell your listeners what triple PD stands for?
Oh, sorry. Triple PD is persistent postural perceptual dizziness.
So, and it's always interesting. So that's if you limit it, it's just dizziness, isn't it? That's your symptom. Whereas FND, it starts to bleed into more other symptoms. Is that what happened to you? You started with dizziness and got other symptoms?
It was more the dizziness more intense until it was 24/7. And then I think it was just it kind of impacted my comorbid other issues. Like I have hypermobility syndrome and stuff. So my joints started to feel more loose, and I'm getting random burning pain in my bones at the moment. So it's just random stuff. So I think we're still investigating. Like I'm still at the very beginning of all this, but it's been going on for like 5.5 years now. So it's like I was classed by a psychiatrist I saw last year as FND, but before that, a neurologist said I had triple PD. So it's
Yeah.
And Shane's asked, is triple PD the new name for FND? No, it's not. It's just like one of those symptoms under FND. So under the FND umbrella, where you could have functional seizures, functional weakness, functional paralysis, this is the one symptom of an FND, and you don't have to have all the symptoms to have FND. But often when you have one of the symptoms, we often develop more and more. Yeah.
So the way this Australian GP talks about functional conditions is, as I do my best to rule out the physical conditions as best I can. Once I recognise something as functional, whether it's triple PD or FND, my approach to it is often the same in a sense. Now, keeping in mind Rachel's comments before, but I fine-tune it to that individual, trying to see what it is that I need to do for that person right now to help the symptoms abate. Americans need a very clear label, so that triple PD, and in America you'll see, very finely new categories popping up in the ICD Cat 10 or one of the categorizing things, because without an actual diagnosis, they don't get paid. You don't get any insurance money. So it's in America, a very clear label is really important. From my point of view, pursuing that label is not necessarily so important. Rather, what I try and do is have that broader understanding of what functional disorders are, and then to say, well, what are your symptoms that we need to focus on? The labels aren't always helpful. Kate, do you agree with that, or do you feel that a label
it can be
beneficial?
Sometimes a label is beneficial because then you know what you're dealing with. So not having a label means you don't know what you're dealing with and you can't seek the right treatment. Like if you know what you're dealing with, you've got avenues to pursue. So certainly when I had no label, and some people have had their FND diagnosis withheld from them, and I was one of them. Not having the label, I've also heard of other people that went into palliative care because they've got all these horrendous symptoms and they think I must be dying. And I remember thinking, oh, I've got this, horrific disease that they just haven't done the right test for, they haven't picked it up. Or there was a label in my hospital records which I didn't know about. So to me, that was worse, not having a label. If you've got a label, you can deal with it. But one thing, in terms of labeling every condition, people get labeled, functional weakness, functional seizures, triple PD, and then people think they've got lots of diseases when really it's all falling under the one that it's just the body's unwell. Really, it's the body is unwell.
I'd like to fully agree with you, Kate, and I write that in my book, is how to utilize labels and how when they work for you, just like Kate described so well there. 100% agree. Yeah. But pursuing every single symptom down to a diagnosis is where you possibly are misspending your energy sometimes.
Yeah. And I guess, because I can see, when you label every single symptom as a new diagnosis, that makes it hard. Rachel's saying labels give me the education to fight it. So, yeah, I'd agree with that.
Yeah.
Catherine's still saying she's not understanding, is FND the same as chronic fatigue, the same as fibromyalgia? So I think she's wanting to know, are they the same or are they separate conditions?
They're separate and the same. So some people have full house of severe physical fatigue and a lot of pain. And then they've got, I would in my notes, I would record both. I'd say they've got fatigue and fibromyalgia. That's how I'd record it. But I suppose I'm conceptualizing both of them, as Kate just said, as you've got an illness caused by the background, whatever it is that's causing all these things to arise in you. My book is trying to get people to turn away from the symptoms, because they often get worse when you focus on them, and towards what are all these causes? What's happening in my life? And I believe a lot of it's genetic, in which case we can't do a lot about that, but it's useful to accept that, isn't it? But then what are the things we can change? And that's where I would put my focus. Don't know if that helps your listeners. Yeah.
Yep, absolutely.
Mm.
And one of the other things we often find is, FND coexists with other illnesses. And, recovery outcomes for FND really depends on what else is going on for that person. Like if someone's going through cancer treatment, their FND symptoms might relate to how sick they are with the cancer, or how sick they are with the treatment for cancer, or an eating disorder, or any other thing. Likewise, if they're dealing with trauma, domestic violence, for some people I've seen, you're not going to get well while you're living in this complete threatening environment.
Absolutely.
So it's sort of like we've got to deal with that environmental situation, because you just can't get well in that environment.
Yeah, so I totally agree, and that's where the focus of my book is to really be clear that when we're talking about physical illnesses, of course we have to focus on the symptoms and get, say you have MS, you need specific drugs to treat multiple sclerosis, for example. But when we are dealing with functional conditions, we're not trying to home in on how to necessarily treat that symptom, because when you treat that symptom and wrestle it to the ground, another symptom could pop up frustratingly, and then you're chasing that as well. Whereas what we should have been doing is focusing on all the factors that are putting you under, your whole body under undue arousal, stress. Your body is under stress. And I often find that many of my patients who have functional conditions, their minds are amazing, like what they take on and what they think they should take on. I'd be very unwell if I did half of what they do. This notion of that they need to or should overburden themselves. And I find it very hard to get people to go like half the workload that you're doing, if you can, and their symptoms might abate.
Hey, Rachel, you've got your hand up, and then I think you've written in the comment. Is that your comment? What to do with the parasympathetic nervous system, or is that someone else?
No,
Okay,
someone
you got your hand up, so you go first.
I believe last year, a female scientist at Griffith University created a test after many years of research with ME/CFS, that's chronic fatigue syndrome, on how to be able to tell from cells from a person's body, based on how the cell processes calcium, if that person has chronic fatigue or not. And she can do blind tests, not knowing if the person has chronic fatigue or not, based on how the cells process calcium, if they do have chronic fatigue or if they don't. So this is the first time a test can be done based on cells without knowing do they have it or do they not. So based on that test, it's possible that this is like the first step in testing, do people have chronic fatigue, like doing a scientific test from like blood test, and B, like working towards a cure in the future. So this is positive. It's possible that some of these like mini diagnoses under the FND umbrella will later find cures that are not functional. It'll later be found that they're not functional. So with FND in the brain, our brain's neural pathways fail to go through our brain's command center and go through incorrect areas of our brain, which create our neurological symptoms under neurological overload. So that's specific for FND. With chronic fatigue syndrome, with fibromyalgia and stuff, I'm not sure that those specific things happen. Yes, they might be functional issues, but they might not have those specific things, that specific mechanism happen in the brain. Is that right, Kate?
So I think
Yeah,
what we're
well,
getting is the functional symptoms versus functional neurological disorder.
Yes.
Because when we
Yes.
think
So
about,
they are separate.
well, yeah, because when we think about our neurological disorder around the seizures, the paralysis, the movement disorders, and then you've got other, like, should it be labeled functional or fibromyalgia or something else? Like, you've got your pain,
Yes.
your fatigue, but then we've also got the neurological symptoms
Yes.
around, yeah. So in the
So
neurological
there's the
symptoms,
FND, and then there's things like fibro and ME, CFS, and
so Rachel,
but they're not functional neurological disorder,
Yeah,
they're functional
functional.
symptoms.
Yeah.
So there's
Right.
a difference
So-
between FND and functional disorders. They're not
Okay.
functional neurological disorders.
Yeah. So Rachel, yes, that's right. That's why I described those 7 systems. And you remember I mentioned the hormones, and I mentioned the
Yes.
inflammatory cells. And inflammatory cells exist in every part of the body, including the brain. So there's some
Yes.
very interesting, very subtle things that can be measured if you're looking very, very closely at brain biopsies, which people don't do, looking at the glial cells and how they interfere with how the brain functions. So, you know, what you're saying,
Functional
Kate, is that
MRIs or other tests
functional
as well, not
MRIs
just
and
biopsy.
very deep research, which we don't have access to. So what I'm trying to do is that, you know, God bless all the researchers out there, may they proliferate and may they produce more data. I'm a simple GP. I'm trying to treat what's right in front of me.
Yeah.
I'm not, my book and my focus is just not on that place. So please keep talking to researchers and good luck to them. But until they come into my room and say, I've got the treatment for your patients, I've got to go ahead and just treat what I can, you know. So,
Yes.
so that's and at this stage, I'm using the research that is based in clinical results. That's why I'm,
Yes.
you know, focusing there.
What's in
But
your
you're right.
office?
Yeah, you're right. There are on functional MRI. We know there are changes that happen. You know, so
Yes.
and does that help? Does it help for people
It
to know
does.
that?
I'm just getting nitpicky about differential diagnoses, and I'm just clarifying that there is a difference between FND and these other diagnoses. They're
We
not
agree.
FND, but they are
Yeah.
functional
Yeah.
disorders or functional diagnoses.
Yeah, and like you
Yeah.
can have irritable bowel without having FND. You can have migraine without
Yes.
having FND. You can have, you know,
Yeah.
fatigue without having FND.
Yeah.
And that,
Okay. I hope I didn't confuse people more. Yeah.
no. And just with that inflammation of the brain, Kasha's done some work around the microglial cells in the brain and the level
That's
of
right.
inflammation, and she's found that is elevated as well.
Yes.
Yeah.
Yeah.
So now the other Rachel's written a comment here around the parasympathetic nervous system. So nothing is working to turn the parasympathetic system. So I think this is when we're in this high autonomic arousal. So you're in that sort of threat response, and the other Rachel saying, I was able to control it. Now it controls me and I can't control it. So it's how do we go into this rest and restorative system in the body when people are so activated in that sort of autonomic arousal? So how are we able to turn it down? So Rachel's saying she can't control this now.
Yeah. All right. And Rachel, that's extremely difficult. And so it does require, you know, you working with people and trying things, and sometimes not switching, but adding, try this and then add something and then add something. It ends up being a full-time occupation for some people to try and get their whole system to go from what Dr. Kozlowski calls the defensive mode. She doesn't just use fight or flight, because fight or flight is only really describing that one system, the autonomic nervous system, which, as you're mentioning now, the parasympathetic system is part sympathetic and parasympathetic are the 2 elements of the autonomic nervous system. And you remember I mentioned there's 7 stress systems. So that's why she uses, and I use, the term defensive mode for when your system's aroused. Each and every one of those 7 systems could be disrupted. Okay, but you're talking about the parasympathetic, so you're talking about the very first system being disrupted. That's the autonomic system being disrupted. And so how do we address that? If you look at, in my book, I kind of list many of the causes that cause the disruption to the autonomic nervous system. It can be childhood trauma, and it's quite common that is an element in people's lives. A background of, anxiety, depression is there. Only about 50% of people can identify something like that. Are you okay, Kate?
Yeah, I've got a dog behind me that's that's commenting and making comments in relation. Sorry about that.
So, and half of people with functional, and I'm talking about more broadly functional conditions, not just FND, half of people would have a history of trauma, anxiety, or depression, some psychiatric component into their condition. The other half don't. So, in the time I mentioned myself, I don't have psychiatric diagnosis, but I did get functional symptoms when I did that. It's a very demanding job at night, so so how to settle the parasympathetic system. Read my book, but going through every single cause, and I would encourage you all to write down every single thing that you think might be putting a strain on your equanimity, on your systems, all those systems. Is it your sleep? Is it your mental health? Is it your diet? Is it your neighbours? Is it your boss? What's causing a strain on you? What are the stories that you carry about the expectations that you have? Are your expectations what you're meant to do too high? Or simply, you might not be able to change anything. You're living in a war zone, or it feels like a war zone, your home.
Yeah, absolutely. And then Dedi's made a comment about trauma and healing. So, some people do have the underlying trauma that can disrupt the nervous system and how the nervous system regulates itself. Yeah.
Debbie, have you got something to add there from your personal experience? Or, I refer people to the Blue Knot Foundation as a free resource, which I find very good, because they talk about how to heal from complex trauma. The first thing they do is acknowledge, which many people have had childhood forms of abuse, discount it. They somehow think it's like, well, doesn't everyone? And that was back then, and I'm fine, I'm past it. It's not necessarily true that you're past it, and it can manifest in symptoms. So I find that website, Blue Knot, BLUEKNOT, blueknot.org, I think is the website. And I've referenced it in the back of my book in the resources, because I think it's a useful source to really start to work on trauma. I don't know if anyone can afford the cost of doing therapy to work through trauma. It takes an extremely long period of time. And I'd be encouraging anyone who has it, to honour the fact that it takes time to heal, and it would take a daily practice. So I say do it religiously. Many people aren't religious anymore, but do a religious practice that you accept on your spiritual terms of what works for you. And I'm not talking about God, I'm talking about what works for you, so you can, to allow whatever healing you can achieve.
And it goes into everyone's individual, and what works for one person won't work for another person. So it's working with yourself. And also you might find, at one stage you're not ready to delve into trauma, or not in that right point, but it doesn't mean that later in the future you might not go back to that. Dedi, did you have any other questions that you wanted to ask? And you're on mute, by the way. Yep.
Thank you. First and foremost, it's really lovely to listen to you, Gillian. Thank you so much for taking your time here to talk to us all. In regards to the healing aspect part, I have talked to some FNDers who were contemplating even talking to a psychologist. Why is that beneficial in this stance? Or in this?
Thanks for asking that. I wrote in part of my book, I've written that I'm not mad, why do I need to see a psychologist? I wrote that out like that because many people think psychologists have a very narrow spectrum, just working on, some mental disorder. But psychologists they often have that hour that your GP doesn't have. They have more skills to help us understand the way our minds work to deal with things. So some people have very poor boundaries and take everyone else's stress on and wonder why they get overwhelmed. And the psychologists can help us to build the boundaries so that we protect ourselves from that overwhelm. They can help us to process an experience that we felt we've dealt with, we haven't actually. And they can gradually allow us time to recognize how impactful that event was for us and bring it gradually so that we can come to terms with that. And we never actually really, I don't like closure. I don't believe in that, but I believe the psychologist can help us grow around that problem so it no longer overwhelms us. That's one of the skills they can help us to bring out, greater strengths in us and shift our focus away from that. They're very good at helping us see our flawed ways of thinking. If I'm a perfectionist, I'm having to do everything perfectly and I'm never, ever measuring up and I'm really critical of myself. That would ruin my mental health. They can help us recognize perfectionism and that demand upon ourselves is problematic and will never allow you to heal from your functional condition. So I think I find them wonderful, but you do need someone who's going to be able to listen to you, and you would need to feel that you can tell them stuff that you may not have told other people, and it has to be highly confidential, and it has to be a place of trust. And trust is something that many of us don't have. We have very good reasons not to trust. Kate, with the way you were treated as a child, by the sound of things, it'd be very hard for you to regain trust in the health system after you've been disrespected, I guess, and not believed as a child. Trust is vital, but that your healing, your healthcare providers and therapists should earn your trust, but you must seek a trusting relationship if you're going to get better
with all your team. And that's one of the issues that a lot of our members deal with, is because they have for so long sort of hit brick walls. They've gone to hospital, really, really severe symptoms, not been heard, not been understood, being dismissed. Trust is something that certainly has failed a lot of people with FND. And one of the concerning aspects is, you mentioned, people with FND still get medical problems. So they still need to be medically reviewed. They can still have strokes. They can still have heart attacks. And if that trust is not there, and we have people go, I need to be just about dead before I'd present to hospital. Whereas that then prevents treatable conditions being treated. So it is important that that trust is there, and that health professionals do listen to people.
So if you're trying to build that relationship with the GP, the standard GP who's got their busy room, you walk in, seek to have an adult to adult relationship first. Meet them in their eye and say, these are the conditions I want to treat. Which ones can we focus on today? And just wait for their response to go, okay, we'll deal with this and that'll have to wait for next time. Yes. Okay. Build a positive relationship on your terms, but have a fairly clear plan about what's realistic for your 15 minutes. Okay. And don't feel rejected if they cut you off at 15 minutes because, they've got a waiting room to look after. I'm trying to be, I'd love you to have the time you need to deal with things. And that's one of the reasons I wrote the book, because I know I never, ever get a chance to fully describe functional conditions to my patients. So, because it's complex and it's multi-layered. So how do you build trust? Try and bring someone with you who can see that how you're being treated and make sure that you're being respected. But I would seek, if you cannot build trust with your health practitioner, I would move. You have to build trust. Yeah.
And that sort of question that we get all the time is, I need a good GP who understands FND. So how do people search for, what are the questions that they should be asking for? If people need a new GP, how do they find one? What are the best questions that they can ring up and go, can my GP do ABC?
That's a really good question. I don't know the answer. I'm an examiner for the College of GPs, so I have to pass them all. But guess what? I don't test them on. I don't test them on functional conditions because it's not in the curriculum. Okay, so I know I'm graduating people who haven't got the knowledge about what I'd like them to have. All right, so we all need to have our expectations lowered here, I'm afraid. And as a GP, why am I okay as a GP after 40 years? Because my patients have taught me stuff, a lot of stuff. Okay, so you're going to need to be the ones a little bit to educate your GP. I'd be very happy if you made sure they got a copy of my book. And as I said, I'll send it to them. You just got to let me know. I'll send it out. But because that would probably help you both at least be on the same page. I do hope that one of the things you can work with is make sure they do you what we call the GP management plans and team care arrangements. Have you heard about them?
Yeah.
GPs are paid quite well to write those, and they're written with a nurse quite often. So you need to practice ideally with a nurse who can help to develop a plan for you. And they're reviewed every 3 months, and you put on that plan your psychologist or your speech therapist or your physiotherapist or your chiropractor or any other person. If you look at, you can get 5 visits a year paid for by Medicare. You probably all know about that. Is that familiar knowledge?
Yeah, it is. I mean, you get your Medicare rebate for 5 allied health sessions. And one of the things that we find with FND, once it's, really progressed, is it's not enough to get people well.
That's right.
Especially
that's
all of allied health.
That's right.
Yeah.
That's true. That's absolutely true. But it's a start. At least you've got some description, some plan, to work from. Yeah. So,
and people have been asking about how can their GP get a copy of this book? So how do they get it to the GP? How do they?
Yeah, I have been giving people my email. Kate, is there any way I can put? Is there anything on the website that people can?
Well, we can put something on the website. So we could put something on the website around, for GPs or other health professionals. They can.
You can go. They can. What's the best way? I should have an answer for this.
Well, we can communicate it later.
Yeah. Okay. We'll come up with a plan. I did offer it on a GP website, and I got swamped with emails, and I sent them all out. That was okay, but it depends how many. I am still a full-time working GP, and I've got a lot of other commitments, so I try and fit it all in. But
I know what
I
it's
would
like.
be very keen for them to have it. I do want them to have it, because the more GPs are educated,
can it
the
be
better.
Distributed through? I mean, like a GP network, like we've got the Australian Association for OTs, and I think there's one for general practitioners. Could it be distributed through there?
I could try that. Yeah. Let's talk after, Kate, and we'll see what we can do. Yeah.
And then for people who want to buy the book, because that's come up as well, and as other people mentioned, it is available on Amazon. So you can get it. I'm pretty sure you can get it on Kindle, and you can buy a hard copy. So and there's a website. So we haven't mentioned your website. There is a website. So Rachel's got Kindle, Audible, Amazon. You can get it paperback, ebook, and audio.
Yeah.
So
no, not yet audio. I've got to work on that. If anyone
okay. So with audio,
so
if you want audio, what I did is, because I find it hard to hold a book, is you get the electronic version, and then I use an app to read it. So I use Speechify. So that was how, so with that, it reads the PDF.
Okay.
So if you have trouble holding a book, turning pages, and you can't hold a Kindle, or your vision's not okay, you can put it through Speechify or any other apps like that to get the audio version.
Great. Okay.
Yeah. Okay, so we'll work on getting this book out to GPs, even through primary health networks might be useful. Any other questions that people want, we should let Dr. Deakin.
So my website's called whatthehellbook.com, and maybe we could put that somewhere too, Kate.
Yep.
Whatthehellbook.com. No dots in there, except for the one. and I sell the book on that website too, if anyone wants to get the hard copy from me. But on that website, I've done a bit of a blog to try and expand on some of the ideas. The blog works upside down, so the first one should be where people start if they want to learn more about it, and work up to the latest one. And very much appreciate feedback on that site, because I get a bit dispirited. I don't know if anyone's looking at it or reading it. So, feedback would be appreciated.
Okay. Okay, Catherine has a question. She's asked for a question. You still here, Catherine?
Yes, I don't have much voice. Can you hear me?
Okay, so Catherine's voice is very quiet. Where is she?
Much for this conversation. I'm most grateful. Is it possible to have your book through Apple Books, which Kindle and Amazon and all those others are not disability accessible for me, and I can't tolerate listening to the voice. I can't follow it properly. However, Apple Books allow you to set the settings in a diverse way, including to make it in a dark mode for people with vision impairments and can't see, have daylight blindness. Would that be possible to organise that?
Something you could work on.
Yeah.
Just doing
accessibility. Feel free to contact me, Catherine, about that. Kate, please send me Catherine's details, or we can tic-tac around that so I can work out how to do that. I'll be happy to do that and let people know about that on my website once I've achieved that. Don't know about that. So thank you. You've informed me, and I'm always learning. So appreciate any of that sort of feedback.
Okay.
And we will see if we can sort that out.
Yeah, I'm sure there'll be a way to do that.
Yeah. The question I have is, how do doctors know? You often hear that FND can coexist with other conditions like MS, Sjogren's,
absolutely,
dystonia and POTS. I'm quite confused because I have systemic autoimmune diseases, and Sjogren's causes impacts like MS, neuro impacts. So I get quite confused, and I think I'm misdiagnosed with FND coexisting. And I don't know how to tell the difference. I don't understand any of this. It's quite overwhelming.
Yeah, that you've got, sounds like you're putting up with a lot of complex symptoms, and it's very hard for a doctor because you're talking about different systems, like the immunologist systems with the Sjogren's, and then you've got neurological symptoms which might have to be diagnosed through a neurologist. Very expensive, very time consuming and difficult.
But they're systemic autoimmune condition. Yeah. And what I'm trying to say is, how do you know, like you were saying before, there are people who've been diagnosed with MS that you have to undiagnose? And I'm just concerned, how do you, as the person living with all of this, these systemic autoimmune diseases cause all of these impacts, like dysautonomia and POTS is very typical of Sjogren's. Sjogren's is not just dry eyes and dry mouths, it's a systemic autoimmune disease, and there's a lot of in the medical profession who don't have any training in Sjogren's. They don't know anything about it. They just think it's dry eyes and dry mouth, and it's not. So and there's a lot of us with Sjogren's who have MS-like symptoms, and we run that risk of getting misdiagnosed with MS. So I'm just concerned, how do we know if you've got a systemic autoimmune disease, that it's, how do they know if FND coexists with these systemic autoimmune diseases?
You're absolutely right that it's a very difficult thing, and it's beyond what I could do as a GP. I'd require a conversation with, say, your immunologist or your neurologist to say, and you can certainly do this, to what extent are my symptoms due to my autoimmune system, and to what extent are my symptoms due to functional? And that opens up that conversation with your specialist who knows the range of symptoms that you might expect with Sjogren's, for example, and say, yes, it's possible these symptoms are functional. And then the only thing you can do is attempt to do what I mentioned in the third part of my book, how to address functional conditions, and see how many of your symptoms abate, because that would be a bit of a sign that they're related to a functional condition rather than your other conditions. That's the best I can do without knowing a lot more about your health.
That sort of goes back to Rachel's point was before, and I think this is what I'm hearing in the Sjogren's and autoimmune disease community. The experts are saying the same thing, is that they don't have all the tests yet. So
no,
that makes it quite difficult when years and years of patients' lives are being lost to very real disability, and they're getting passed from people to people, and serious issues are being lost. And in the meantime, they can't get access to NDIS, they can't get access to DSP or what have you, because nobody really knows what's wrong with them. And they can be treated like they're hypochondriacs and subjected to all this stigma when something is seriously wrong. I just don't know how patients are meant to navigate all this when, you know, for someone like me, I can't see properly, I can't read, I can't remember. It's not always possible for us to become.
Yeah, you're not doctors. Yeah, it's really hard. And we do get like functional overlay. So like with MS, you can have functional overlay as well, where your symptoms are worse than what would be predicted by the scans. And you're right. I think so many people with FND have other conditions which all sort of worsen the body systems. And it makes it really hard. So you're dealing with those certain conditions. Other people have other different conditions that they're dealing with where they've got FND and other conditions. And so often we don't know what's due specifically to the FND, what's due to the other conditions. And it's sort of like it's a whole body. We've got symptoms in the whole body. We've got to work with that person. And you mentioned NDIS. NDIS is a nightmare because they put people into boxes and they diagnose different conditions and what they accept as a primary condition when all these other conditions feed into it. So it makes it really hard for everyone to navigate, the person living with it, and I guess the health professionals, because no one fits into these neat boxes.
And is it possible that all this stress and complex trauma, if you don't mind me saying, I live with complex PTSD. It's not just from childhood adverse events. There are lots of causes for complex PTSD, including years and years of medical trauma.
Absolutely.
The question I would be raising is these systems that vulnerable people have to navigate, oftentimes without any support and horrific things happening to them, and the stress even of dealing with NDIS.
Yeah, absolutely.
Should be contributing to deterioration and degeneration for
it absolutely does. So the stress of NDIS and any sort of legal processes that people end up with just to get their basic disability needs met do exacerbate the condition.
And that's why an organisation like FND Australia is so important, that people support each other and find ways to help, and so my tiny contribution to that is to try and just encourage you to do the things that you might be able to do and take a sense of agency about, can I make myself fitter despite my disability? And the can I nourish myself better? Can I work to reduce my stress, physical, psychological stress responses, to ease some of the strain you're taking on your system, because it's incredibly hard. I don't expect you to be 100% successful with that, given the load you're carrying, Catherine, but it's at least maybe you can abate some of the symptoms. That's what I'd be hoping for.
I'm just raising it not just for me, but in recognition that I'm not unique.
Yes.
Look, I see it. Yeah, everyone has different combinations of underlying conditions, but the people that I see with FND who are not like recovering are the people who have multiple underlying conditions and or stresses in their biopsychosocial stresses as well. So it is a really complex thing to navigate, and a lot of people are left trying to manage this system, trying to manage the health system, trying to manage the disability system, the welfare system if they can't work. And it is really hard. And it just adds to the stress that the individual's dealing with, especially when you've got a level of disability. Catherine, you mentioned that, your vision's not great. And if you don't have good support structures around you, it adds to the level of distress because
well, there's a lot of things that I can't do.
Yeah.
Really communicate, and I can barely use my hands. The unique aspect for me is I fall into a very rare group of the Sjogren's lupus community that reacts very severely to ultraviolet light and near UV frequencies of light. So there's a lot of damage that has been done and a lot of disability barriers. But I think the hardest thing for me is when your brain and your ability to even remember things or understand things that's affected, and you can't see, you can't hold a book.
Yeah.
Yeah, I suppose, Catherine, one of the things that I was hoping...
Quite stupid.
Yeah. You want to keep going?
You feel quite inadequate to the task of becoming, doing a medical degree.
Yeah, I think a lot of people feel like that.
When you're flat out.
Yeah, when you're so unwell. Yeah, Dr. Deakin, did you want to comment on that?
Yeah, I just picked up, I don't know if I misheard you, Catherine, but I think I heard that you're saying, you've got these functional conditions are causing damage. And while they cause nasty symptoms and disability, it's important. One of the only good things about having a functional condition is it's unlikely there's tissue damage. And if there was tissue damage, that's the sort of thing that tests can find. And that's why it's so frustrating to have it, because all the tests come back normal.
That's what I get across is I have very real damage.
Yeah.
That's autoimmune. So when somebody comes along and says, oh, you have FND as well, I don't know that I believe them. And that, because from what I understand, they haven't convinced me, they haven't given me the evidence to show me that I have this other label. I've got enough labels.
Yeah. And that's where we have like your underlying medical illnesses. So you have like potentially you have a functional overlay on top of your other conditions. And if your other condition is treatable, then your functional symptoms sometimes improve. But when it's not treatable or when it's progressive, that's when we often see your FND symptoms worsen. So you will need a really good GP to stay on top of that. And it is hard. And you can't always put them into boxes. You can't always go, well, this is because of my underlying physical disease and this is because of my FND. It's impossible to separate because we're a whole person with multiple different things happening in the body. Anyway, we should wrap up soon.
Thanks for explaining that.
Dr. Deakin, was there any other comments that you wanted to make before we wrap up?
Well, I just think, it's so wonderful to see your organisation thriving, Kate, and a credit to you for all the hard work you've done. And thank you so much for this opportunity to talk with you and have a brief chat with some of your members. And, I just have enormous admiration for the courage that people have to live each day with these disabling symptoms, and the fact that they, even bothered to give up their own Sunday to come here today. I really, honour each and every one of you, and just to say, just don't lose hope. Keep trying. It's totally understandable why this is dispiriting, but this organisation is a great starting point. And if my book goes a little bit towards better understanding, then I'd be very happy. And I think it'll be a long process, but I think the tide's changing. I think FND didn't even exist as a term. What, Kate? How long we had the term
sort of, 2013, it was in brackets in the DSM-5, and it's now the revised version where it's out the front. So, back in the day, it was all
time to change.
Yeah, it is definitely changing. We sort of see, pockets of excellence, and then you hear about bad experiences, but overall, it is improving. And the more we get out there, like this book is accessible to people to help them understand the condition, make potentially some sense of it, and also to get out to the GPs. So the more we can get the message out and train up GPs and train up our medical specialists so that they are informed before people present to them is really helpful.
Yeah. And it is helpful if you can go in, to what extent could my symptoms be functional? And that would help the doctor to go, great, this patient, there won't be this huge debate about whether your symptom might or might not be functional, or do functional conditions exist? Yes, they exist. Yes, they exist. Does this particular symptom relate to my functional condition or not is a delicate and difficult question that you have to take to your specific doctor. It's a very important one. But if you go in there with the notion that functional symptoms are common and I accept I may have some, that helps the doctor. That helps them enormously to then go, okay, let's try and tease this apart, right? So you're making their job easier if you're well informed about the fact of functional conditions, and then trying to sort it out. That's the best I can offer you today.
Great. Well, thanks so much, and thanks for your time and everyone attending. It's always great to see more and more, health professionals from different fields getting an interest in FND. So this is a great start for the GPs, because that certainly has been an area where people used to come to us and go, how do I find a GP that even knows of this condition? So if we can offer them a book to go, here's a readily accessible book, that's wonderful.
I've been publishing some articles in Australian Doctor, which is read by many GPs, and that was well received. So there's a little
excellent. So we're all sort of making small steps, which can have big impacts.
And the work by Dr. Louise Stone, some of you may have heard, another very venerable GP I hold in very high regard. She's done some wonderful work on functional conditions as well.
Fantastic.
So Dr. Louise Stone.
Yeah, awesome. All right, well, thanks so much for your time, and we can be in contact around the distribution of the book and how we promote it. But awesome. Okay, well, thank you.
Thank you all.
Okay.
Bye-bye. Thank you,
Bye.
Kate. Bye-bye.
Bye.
Bye.